I'm Michael Caruso. I'm the editor-in-chief of Smithsonian Magazine. I have one of those impossible roles here, introducing a man who needs no introduction, especially to the people in this room, but I'm going to plow on anyway. So bear with me. When it comes to thinking about epidemics, everybody wants to talk to Tony Fauci. He's been America's point man on infectious disease for 33 years now. He's led our nation through every infectious disease crisis through those years, from AIDS to Ebola to Zika. Dr. Fauci is a member of the National Academy of Sciences. He has 42 honorary doctoral degrees. He's received the Presidential Medal of Freedom, and his citation reads that it is for his commitment to enabling men, women, and children to live longer, healthier lives. With his broad appreciation for the public good and his nonpartisan nerves of steel, Dr. Fauci oversees a $4.9 billion annual budget. The stories in our new issue of Smithsonian Magazine and this event itself grew out of an answer that Dr. Fauci gave us that was posed to him on stage at another event of ours a couple years ago. We asked him, "What concerns you most? What keeps you up at night?" And his answer was simple, 2 words: pandemic influenza. Okay, we thought, let's hear more about that. Ladies and gentlemen, Dr. Anthony Fauci.
Thank you very much for that kind introduction. So following that encouraging story from John, I'm going to tell you a little bit about the next step that I think John was very clearly referring to about what we need to do regarding preparation. And that's what I'm going to talk about in my 10 minutes, namely preparing for the future in pandemic influenza. So the first thing that I want to do is to make the point that when you look at influenza, the preparation for seasonal influenza essentially should be the preparation for pandemic influenza in a perfect world. And the perfect world that I hope we get to within the next period of years, we certainly are trying hard for that, is the development of what John alluded to is a universal influenza vaccine. And let me tell you why, as someone who's an infectious disease person, that I am concerned about our capabilities today against any kind of influenza. So I want to break it up into 3 quick parts. First of all, the current seasonal influenza vaccines are not consistently effective, and that's a fact that we just have to face. If you look at from 2004 until the last year, when you have a bad year with a mismatch, as we saw in 2004-05, you have a 10% efficacy. At best, as we had in 2010-11, you have a 60% efficacy. Compare that to other infections that we have vaccines for. Measles vaccine is 98.5% effective. Yellow fever is 99% effective. Polio is more than 90% effective. Now, there are a lot of reasons for that. We all know about the drifts. We all know about the mutations. We all know about the fact that the response against the hemagglutinin, although it can be very effective, drifts from year to year and sometimes shifts. But this is the stark reality of how we address seasonal influenza. Now, pandemics do occur. You just heard from John about the mother of all pandemics, but we've had 3 since then, in 1957, 1968, and the most recently in 2009. However, the response after the fact is not effective. Now, John alluded to the 2009 H1N1 pandemic, in which we actually had a bit of warning. And I want to show you what the response was of those of us who were going as quickly as we possibly could. So it was the swine flu. The first thing is that we were expecting, as we always have, that the next pandemic would come out of China or the Far East, when in fact it did not. It came right in our Western Hemisphere, somewhere around California and Mexico. Now, you recall, and I'm sure people in this audience do recall, that at the end of the 2008-09 season, as things were coming down in March, the way they do, it usually peaks in January, all of a sudden, in March and April, we started to see a new kind of influenza. And so we felt, let's make a vaccine for that influenza. And this is March. This is what happened in April. So it wasn't a 1976 shoot from the hip and get into trouble as we did then by vaccinating everybody when we never got the epidemic. We knew we were going to get a pandemic. So in April, this is a picture of my good friend Ann Schuckert and I testifying before our Appropriations Committee in April, saying, and you could go back and see what we said, is that it's April. It takes about 6 months to get a vaccine going. So if we start working now, May, June, July, August, September, October, if we have the vaccine by October, then we'll be prepared for the inevitable pandemic. However, what happened? The children came back to school, and instead of having an epidemic or a pandemic that peaks in January and February, it peaked in September, as graphically shown on this slide. So what's wrong with this slide? The blue line is where the red line should be, and the red line is where the blue line should be. In other words, the percent of illnesses peaked before we had the vaccine available, which became available. It would have been wonderful if it had a peak in January, but it didn't. It peaked in September. So even though we have some warning about a pandemic, even then, with our current capabilities, it doesn't work well. This is a picture. Notice the expression on Tom Frieden and and Jesse Goodman explaining to the House Oversight Committee about the vaccine that we were supposed to have in time. We didn't. And then there's the third thing, and that is chasing after potential pandemic outbreaks. I refer, and others refer to them as pre-pandemics. It is costly and it is ineffective. And let me just give you a couple of examples. You all recall the H5N1, the chicken virus that started in Hong Kong, jumped species, had a high degree of mortality, but didn't develop the capability of going efficiently from human to human. We took this very seriously. And what happened, it was during the George W. Bush administration. He asked for over $7 billion, and we spent about $4 or $5 billion to switch from eggs to cells, which I don't think is a very major advance, as we'll get to in a second. But we made a vaccine, we put it in the stockpile, and nothing happened. But we did do something really good. We put a pandemic influenza preparedness plan involving what you see on this slide. We approved the vaccine that we had. The first adjuvant at H5N1 is available, stockpile. We didn't use it. Then what happened is several years later, we had the H7N9, same thing. Chicken virus jumps from chicken to humans, high degree of mortality, not efficient from human to human. It started in 2013. We were quick. We made a vaccine in 2013. We stockpiled it. There was a mini outbreak in China in 14, 15, 16, and then what happened in 17? It mutated a little, and the virus and the vaccine that we had for the 2013 strain was not protected by the vaccine that we developed for 2017. So we had to go back again and start all over again. What is this telling us? This is telling us my conclusion, that we need to get a universal influenza vaccine. It's going to be incremental, it's going to be iterative, but I think from a scientific standpoint, we will get there. Well, we will if I get this. Okay, just very brief for about 30 seconds. There are a number of ways to get a response that is universal against all viruses. One of them, not the only one, and I want to emphasize, is that when you look at the hemagglutinin in the head and the stem region, it's very clear that sorry, this is not working well. Can we go back one? Okay. There you go. So I'm sure people in the audience are very well aware of that the part that is protective in the current vaccines is the head of the hemagglutinin. That's the good news. The sobering news is that that's the part that mutates or drifts from season to season or shifts when you get a pandemic. To make a vaccine with a response against the conserved regions in the stem is one of the ways that we are pursuing, and a variety of others are pursuing, to try and get a vaccine response that is against virtually all strains. So I want to close on this slide. We had just written this for Scientific America, and it's somewhat of a pessimistic statement, but I use it not for pessimism, but to spur us on to the goal of what we need to do, because 100 years after the lethal 1918 flu that John just described, we are still vulnerable, and our public health infrastructure has improved greatly, but without a universal vaccine, a single virus would result in a world catastrophe. Thank you.